John's at Upstate Orthodontics on Frontage Road in Clemson. He's the only orthodontics practicing in the area, but he's going to talk about modern orthodontics and temporary anchorage devices. Yeah.
Well, hopefully I won't bore you guys, but like she said, I'm an orthodontist here in Clemson, Seneca area. I've been practicing for a little over a decade. Graduated from Francis Marion in '89, at dental school in '96, and my residency in '98, which I did out in Kansas City. I do limit my practice to orthodontics, but orthodontics has changed significantly over the past decade. I want to talk to you about this painting right here. Can anybody tell me what type of painting that is?
Impressionist.
There you go. Paying attention. It is impressionistic painting. And so the reality of it is that paintings have changed. And that's an actual photograph that's been painted digitally. And as art has changed, as photography has changed from film to digital and to the different things we can do, so has orthodontics. And today we're going to be talking about just the changes in orthodontics and how that will relate to you when you either practice in medicine or dentistry in the future. This is a nice set of chompers, pretty much an ideal occlusion. And when we talk about teeth, it's more than just straight teeth. It takes more than straight teeth to make a pretty smile. It takes pretty straight teeth. The reality of it is your eyes are drawn to asymmetry, and so when you look, you'll see things that are maybe asymmetric, color. There's different things that you may not pick up on when you're looking at a nice occlusion or a nice bite. You may look at someone's smile and not see that it's quite right and not be able to put your finger on it. But we're looking for symmetry, and we're looking for midlines being on, and nice bright teeth and well-proportioned. Things on the right and left are pretty much symmetrical and that they fit together properly. Orthodontics is constantly changing. It is a changing tide. Our treatment options change on a regular basis, and basically the options that we present to patients will be different for different practitioners. And we're all biased due to our past experience as well as our level of knowledge and the comfort that we have in doing the type of things that we do in our practice. Continuing education is essential to be a good practitioner these days. You can't just learn what you've learned. You can. There's some people who learn what they've learned in dental school or in their residency and don't really deviate from that and do this, practice the same way now that they practiced a decade or 2 decades ago. And you can certainly do that, but your patients will be missing out. There are certainly some changes that allow us to do things we used not to be able to do. And it's important that you read research, and not all research is good research, but evidence-based research is what I base most of my decisions on, and that is the fact that there are lots of things that we do in practice, and we look and say, wow, that worked out great. This did what I thought it was going to do, and in my hands, this works well. Well, the fact of the matter is that we get fooled all the time. Every patient's different. Different patients react differently. If we're looking for consistency and looking to deliver quality result, we need to base our decisions based off of what really happens. And how do we know that? Do good research. Research with good controls and double-blind studies, and so we can take biases out of it, and then we come up with really what good treatment is. Self-ligating brackets. Now, this particular case, I finished him a year ago. And when you look at this, how many people have had orthodontics in the room? Okay, so about half of you. How many people had extractions? Okay. Now, when I look at this case, if I would have treated this even 7 years ago, I would have taken out teeth. There's a lot of crowding. There's a good bit of crowding on the bottom, a good bit of crowding on the top. And he's an adult, and how much can you remodel the bone? How broad or how far forward can you push things and not stress out the gum and bone? Because the reality is when we're moving teeth, we're remodeling bone. And that's what we do. Bone physiology, bone morphology is what we do. Teeth don't magically change. They don't change necessarily during the course of treatment, but the bone does. And all we do is put life forces on teeth, and the bone remodels around it. So we stimulate the bone to change. And bone unlike what most people think, bone is a living tissue that is constantly changing. And all of those who've had orthodontics in the past, you've probably noticed there's been some changes with your teeth and occlusion. Whether you've had orthodontics or not, your teeth can move at any age. And so retention is important to keep things where they are. But when I look at this case, today I look at it differently. And because I had done more with self-ligating brackets, a lower friction way to move teeth, there's some advantages to that to the type of brackets that I used to use in the past. And there's a big marketing push for everything in orthodontics. Ooh, this is the best and this is why, and that sort of thing. So you really have to be careful. I started using self-ligating brackets because it was going to save me chairside time. We schedule our patients for half an hour, and to do an arch wire change, it would pretty much take us half an hour because we steel tied every tooth. You've got the bracket and you've got the wire, and we'd steel tie the bracket to the wire. Now, the fastest way to do it is to put an elastic tie on there, little colors that you see people do all the time. The problem with that is it adds friction and it's a plaque trap. The better way to do it is a steel tie, but it takes longer, so most orthodontists don't go that route. Well, with self-ligating brackets, you open the door, you put the wire in, you close the door, and you can do 2 arch wire changes in the amount of time that it takes to do 1. So I looked at it as, it's marketed to move teeth faster and that sort of thing, but I looked at it as, well, if I use these, I can be more efficient with the patient in the chair. So there's practice efficiency, how fast we can do things, and then there's patient efficiency, how fast does the treatment progress, and then there's the type of results that we get. So in this particular patient, you can see this is kind of a mid-course treatment thing. You can see how the lower arch is starting to develop out, and the upper arch is broadened, and the teeth are straighter, and we get to this point, and here's the end result. And he had some veneers. If you look back at this particular picture, his incisors are broken. He ended up, we got his braces off, he got them bleached and got veneers, and this is the end result. Now, the reality of it is that self-ligating brackets, although changed how we do things, they have also changed slightly what we can do. Because in the past, when I had a lot of crowding and I would unravel, the teeth would go forward and it would really stress the gum and bone on the anterior incisors. But now I get lateral expansion. As you can see with him, I got a lot of lateral expansion, which is difficult to do when you have a lot of friction built into the system. And what I mean by that is, let's just say we want to put 50 grams of force on a tooth to move it, and we have friction built into the wire. That wire has to slide through every tooth for it to expand laterally. And I have to overcome the friction points on the bracket and wire interface. So if I need 50 grams, I may have to put 150 grams to overcome all the friction points. And every now and then the friction points will break and I'll have too much force on there, but it's not a light, consistent force. So self-ligating brackets allow us to do that. But it's changed some of how we do things, but not the big picture of what we can actually do. I mentioned when we were talking earlier, I'm into photography, and I've been lucky enough to be on the field this past year, and so you'll see some kind of football pictures throughout. But that was a Wake Forest game, and Kyle Parker dived and dove into the end zone. It was pretty good. But this is mainly what I'm going to be talking about today, and this is temporary anchorage devices. And temporary anchorage devices are basically mini screws. They're little mini implants, little bone screws that we put into the bone. And most of people who go into orthodontics, they go into it and they don't give shots anymore. We don't do any of that stuff. I mean, we delegate most of what we do, and we see patients in a big Bay Area, and we don't do fillings, we don't pull teeth, we don't give shots, we don't cause pain. So the idea of going back and putting a screw in somebody's head is not very appealing to most of us, especially if you've been out for a decade. Learning in the university setting when it's not your patients and your practice is one thing, because it's really, you're a bystander there. You get to leave, you get to pick up and move, but when you're in your hometown, or you're in your town where you live and your patients, that stuff's going to stay with you. So it's a little, learning to do something that's maybe a little bit different is a little bit more taxing, but basically the anchors are a paradigm shift. They have changed orthodontics, and all of the residency programs now teach it in their programs. And but they've only been out for about 5 years. And but they change what we can do. They change the fact that we can do tooth movements we used to not be able in the past, because before we couldn't move teeth up. We had nothing to pull up to. We'd have people wear headgears, but they wore them intermittently. But if we can put a light continuous force up, we're remodeling bone, the tooth will move that direction. We used to not think we could distalize teeth. Why? Because there was nothing back there to pull from. But the bone doesn't know any different. The tooth will move distally, just as it will move medially, but we have to have something back there to pull from. So anchors allow us to do movements that used to be impossible. There's different types of anchorage devices. There's the mini plate, which is this one up here, that requires a surgical procedure, moving the gum tissue back to place it, to remove it. So 2 surgical procedures. An implant, same thing. And then the endosseous implant on the top right over there, that's like you put a crown on top of it. So you can use it for orthodontics, and then you can put the crown on top of it. And that's about a $1,500 surgery for the implant, the titanium implant. These screws, when we buy them, they're about $80. So we charge $250 to put them in. But the reality of it is that what I can do with these anchors now has changed a lot of our options. We can put them in between the roots of teeth, and it allows us to do, it gives us control in a very quick fashion, and we don't have to do surgery to do that. It gives us vertical control. We can move teeth forwards and backwards, and we can do that without having the reciprocal forces that maybe we didn't want to do. There's different types of facial patterns, and some people we want to take out teeth in because it's going to improve their facial patterns, and other people have recessive lips and we don't want to take out teeth on them. And so if we've got someone who's missing teeth, we've had to replace them because we couldn't close space without the compromises that we would make. We've made compromises so long, we don't see them as compromises. It limits the type of auxiliary appliance that you use, and it gives you a stable platform. This is some new stuff right here. But it also preserves bone. And this is basically, I'll just kind of go through this real quick. This is the system that I use. There's lots of different anchors out there. These are what I use on. This is the very first patient that I did, and in this particular case, if you take a look here, he's got a lot of crowding here, and he's got a lot of crowding up here. And most people would look and say, okay, wow, we just need to take out teeth, and that's exactly how we would handle it. But when you look back here, he's missing another molar. So he's already had a molar extracted here, and he's got this tooth blocked out. Now, there's really no way for me to open space and make that room. So I would, in the past, would have taken out this bicuspid, moved the tooth in, and then up here, I would have taken out this bicuspid, moved the tooth back, and closed the space down here on this side right here, and taken out another tooth over here, and that would have kept everything symmetrical and would have gotten the job done. But this particular tooth up here has got a root canal and crown on it. It's compromised. This is a healthy tooth. Why do I want to take that one out? Well, because it makes orthodontics easier. But what if I took this one out and brought this tooth back to make room for it? What if I was able to distalize these 3 teeth? I would save him for having to have a tooth replaced, because having a canine, 2 bicuspids, and a molar is perfectly normal. Okay, you could be missing a molar or bicuspid and have good occlusion. But having a canine, 1 bicuspid and a molar, he really needs to have another tooth. So if I can retract these teeth with a $250 anchor, I'm going to save him a $3,500 implant. So this is the very first case I did, and I didn't really know. It was in the literature, and I didn't really know what was going to happen. But I had the oral surgeon place an implant, and he placed, or an anchor, he put one in the posterior ramus of the mandible and one in the maxilla. And over time, and you can see over the course of 8 months, you can see these 3 teeth distalizing. And you know, up until then, I'd never distalized teeth because never had the ability to do it. And nothing magical about it. Teeth don't know what they're supposed to do; they just remodel the bone. And basically, through the course of treatment, you know, this is about 22 months into it, and this is where he finished up. And there's some things that I would like to have done differently, but he had moved and was living in Columbia and was in the police academy or something like that, but he couldn't get back up, so we basically wrapped it up. But certainly better than where he started. This is Spiller. I think this is a TCU game. Spiller rubbing the rock. This is actually a patient that's not mine. This is from a European country, and I show this for one reason only. This particular patient's missing 6 teeth, missing 4 on the bottom and 2 on the top. So